All right, let's just jump right in. You're in OB nursing. It feels like this mountain of information, and I know your exams are probably right around the corner. I totally get it. So think of this as your game plan. We're going to cut through all that noise and really focus on the high-yield stuff that's going to make the biggest difference for your exams and for your future patients. Sound familiar? You're trying to connect the dots between like a dozen different high-risk conditions, all these meds, fetal monitoring strips, and yeah, it is overwhelming. But what if I told you there's a simpler way to see the big picture? A way to focus your study time on what really, truly matters. Okay, so here's our strategy. We're going to use the 80-20 rule. We are going to laser focus on that 20% of OB knowledge that you see again and again on exams, and that is just absolutely critical for keeping your patients safe. If you can master this 20%, you are setting yourself up for 80% of the results. It's all about studying smarter, not just harder. So here's our roadmap. First, we'll get into the single most important mindset for high-risk OB. Then, we'll dive into the one concept that ties almost everything together, perfusion. After that, we'll cover how to tell if the baby's okay, the can't-miss maternal red flags, priority tests and meds, and then finally, we'll wrap it all up with a super simple action plan. Ready? Let's do this. First things first, we need the right framework. You know, instead of just trying to memorize hundreds of random disconnected facts, we're going to build our entire understanding around one central idea. And this is the key, really, to seeing the patterns that your instructors and the NCLEX just love to test. And here it is, the one concept, perfusion. More specifically, uteroplacental perfusion. Honestly, if you can wrap your head around this, you understand the why behind most of what goes wrong in high-risk OB. This isn't just another fact to memorize. It's the lens you should use to look at every single high-risk scenario. So what even is uteroplacental perfusion? Well, simply put, it's just the delivery of oxygen and nutrients from mom through the placenta to the baby. Think of it as the baby's lifeline. That's it. And when this lifeline is compromised, the baby is in serious trouble. It is the root cause of so many problems we see. And check this out. This slide really drives the point home. Look at this list. These seem like totally separate risk factors, right? But think about it. Chronic hypertension and preeclampsia. They wreck the blood vessels. Uncontrolled diabetes? That creates this sugary, inflammatory environment that's just awful for circulation. Smoking reduces how much oxygen the blood can even carry. All of these different paths lead to the exact same place, poor perfusion. They attack that vital lifeline to the fetus. So, if poor perfusion is our main enemy, how do we know for winning the battle? How do we know if the baby is actually getting enough oxygen in there? Well, that's where our fetal surveillance toolkit comes in. These are our eyes and ears. Okay, before we even touch a fancy machine, our first and maybe our best indicator is just fetal movement. A baby with plenty of oxygen moves. A baby who's in distress often gets really quiet to try and conserve energy. So let me be absolutely crystal clear. If a mother calls you and says, "My baby isn't moving as much," that is a top priority, red flag, all hands on deck statement. It requires immediate evaluation, period. All right, when that mom comes in, one of the very first things we're going to do is a non-stress test, or an NST. And this comparison right here, this is a classic exam question. A reactive NST is good news. It's reassuring. It means the baby's heart rate went up with movement, which tells us they're well oxygenated. That's our green light. But a non-reactive NST, that's a major concern. That's a red light. It tells us something might be wrong with perfusion, and we need to investigate right away with the next test up, a biophysical profile. So the biophysical profile, or BPP, is basically a report card for the baby, and we do it using an ultrasound. We're checking 5 key things that tell us how the baby's central nervous system is doing, which of course is directly affected by oxygen and perfusion. A score of 8 to 10? Awesome, we're happy. But look at that bottom line. A score less than 4 is a critical finding. It often means the baby is in serious trouble, and the priority nursing action is to get ready for an immediate delivery. We've looked at the baby, now let's shift our focus to the highest yield maternal conditions. These are the diagnoses that are life-threatening, and I can pretty much guarantee they are going to show up on your exams. You absolutely cannot afford to miss these. Here it is, a top exam trap, mixing up gestational hypertension and preeclampsia. The key difference, the thing you have to remember, is end organ damage. Gestational hypertension is just high blood pressure. Preeclampsia is high blood pressure plus signs that the mother's body is starting to fail.
That end organ damage means the perfusion crisis is now affecting her brain, causing headaches, vision changes, her liver causing that right upper quadrant pain, and her kidneys. That is why it is a true medical emergency.
Now for a condition that might seem less dramatic at first, but is incredibly dangerous: cholestasis of pregnancy. The hallmark sign is unmistakable: intense itching, especially on the palms of the hands and soles of the feet, and it's always worse at night. And here is the key exam tip: there is no rash. This is not a simple skin issue. It's a liver problem where bile acids are building up in the blood, and that creates a toxic environment for the baby, posing a really high risk of sudden fetal demise. Okay, let's move on to the tests and medications that carry the most weight. Knowing these inside and out is it's non-negotiable, not just for your exams, but for safe practice. When it comes to invasive genetic testing, you are definitely going to be asked to compare CVS and amniocentesis. The most testable difference is the timing. A CVS can be done much earlier, using a tiny sample of the placenta. An amnio has to be done later, using amniotic fluid. For your exam, just lock it in. CVS is earlier, amnio is later.
You will 100% be tested on RhoGAM. It's such a critical safety medication, so let's break it down. Who gets it? The R-negative mom. Why? To stop her body from making antibodies. See, if her blood mixes with an Rh-positive baby's blood, her body sees the baby's cells as invaders, and it creates an attack plan. RhoGAM basically goes in and cleans up any of the baby's cells before her immune system even notices they're there. It protects future pregnancies. When do we give it? Around 28 weeks, and then again after birth if the baby's Rh-positive. And your number one nursing action: double-check that blood type, and then monitor that mom closely.
So, we've covered the core concept, the assessments, key conditions, but how do we put it all together when you're actually at the bedside? Let's build a simple, repeatable action plan that will help you think like a safe, competent nurse. This right here is your mental checklist for any high-risk scenario. Step 1, recognize the cues. What's abnormal? Is the BP high? Is the baby not moving? Step 2, analyze those cues. Connect the dots. A high BP plus a headache isn't just hypertension. It's probably preeclampsia. Step 3, prioritize. What could kill my patient or the baby first? Fetal distress and hemorrhage are always at the top of the list. And finally, step 4, take action. Start monitoring, call the provider with clear data, and keep your patient in the loop. And let's end with this. Your assessment skills, they're your superpower. You have to trust what you see, what you hear, and what that monitor is telling you. But in OB, you must always be thinking one step ahead. Always be prepared for the worst-case scenario. That vigilance, that proactive thinking, that is what separates a good nurse from a great, and most importantly, a safe nurse. Now go be that nurse. You've got this.